Pes Cavovarus. These patients have a high medial arch and think of neurological involvement until proven otherwise. Regarding the history, the patient will come up with complaints of lateral aspect of foot pain with instability, especially in patient with HSMN. Patient would have walking difficulty, wearing shoes, and neurological symptoms. Regarding the clinical examination, I need to check the footwear, which will have more wear laterally. The patient can have a foot drop and would have a high medial arch. Need to examine the hand and the spine. Unilateral causes are by the spinal deformities, spinal cause, while the bilateral is usually the Charcot-Marie Tooth disease. On standing, I will assess the arch, which will be high. I should comment on plantar flexion of the first metatarsal, hind foot varus, clawing of the toes. I will ask the patient to sit down and palpate all the callosities and lateral aspect of the foot and metatarsal head. Check of the range of motion, which is active and then passive, and check for the correctability of the deformity. I will also check for the muscle power, specifically for peroneus longus by resisting plantar flexion of the first ray, peroneus brevis by eversion, tibialis anterior by the ankle dorsiflexion, and tibialis posterior by inversion, and check a neurovascular assessment. Once done, I will do a Coleman block test for the patient and do a silver squid test. A Coleman block test will tell me if the deformity is hind foot driven or forefoot driven, and silver squid test will confirm if there is gastrosoleus tightness or Achilles cord tightness. Regarding the causes, as I first said, I think neurological. It can cause by neuromuscular problems, trauma, congenital, or idiopathic. In neuromuscular problems, hereditary sensorimotor neuropathy, Charcot-Marie Tooth disease, spinal cord lesion like ALS, Friedreich ataxia, polio, tethered cord, diabetic neuropathy, CP, and a stroke. In traumatic posterior leg compartment syndrome, malunion of the calcaneus fractures, or peroneal nerve injury after a knee dislocation. Congenital, it can be because of incorrect or partially treated clubfoot. Idiopathic can be subtle cavus deformity with no neurology, with ankle osteoarthritis or rheumatoid arthritis. Regarding clinical assessment, after clinical assessment, I will do a radiological assessment. I will do a weight-bearing AP and lateral view. Check for the Miri angle, that is first metatarsal and talus axis. Hibbs angle, which is the first metatarsal calcaneal angle, and calcaneal pitch. Regarding the angles described, Miri angle is 0 to 5 degrees, which is first metatarsal and talus angle. Hibbs angle is first metatarsal to the calcaneus angle, which is normally about Hibbs angle is normally less than 45 degrees. And calcaneal pitch is normally 10 to 30 degrees, which is increase in cavus deformity and reduced in planus deformities. Regarding if the patient is having a unilateral deformity, I need to check for spinal problems and would prefer to do MRI to exclude the spinal dysraphism. The management is multidisciplinary team approach, which consists of pediatrists, neurologists, orthotics, and surgeons. Orthotics are basically corrective rigid insoles with depression of the first ray and a lateral wedge. This allows correction of the deformity on the hind foot, and they can be also accommodative if they are fixed deformities. A surgery should not be indicated if there is a progressive neurology. Regarding the surgery, soft tissue release, i.e. tendoachilles and plantar fascia, tendon transfers, that is peroneus longus to peroneus brevis, and tibialis posterior transfer to the dorsum of the foot. The osteotomy is lateralizing calcaneal closing wedge osteotomy or first metatarsal or cuneiform dorsiflexion osteotomy. In severe cases, fusion is indicated for the hind foot. For the clawing or the hallux at the first ray, as EHL is recruited, the procedure is a Jones procedure in which you do fusion of the interphalangeal joint and the EHL is transferred to the level of the neck first metatarsal. For the rest of the toe deformities, I can do a flexor tenotomy, IP fusion or excision. There is a law called Cook law for the foot deformity correction. Number 1, get the heel under the calf. Number 2, put foot square on the floor plantigrade. Number 3, balance muscle. Number 4, varus flexible forefoot surgery, varus fixed forefoot and hindfoot surgery.